Okay, perfect. I think we'll give it a start, make a start, and people can join us if they're running a few minutes late. So welcome everyone. My name's Hannah Hollis. I'm from Thames Valley Cancer Alliance and have worked with Peter Hunt at the CCG to set up this education session today. So the session is going to be on cancer care reviews. Just a few little housekeeping bits and bobs before we get going. So if we could ask everyone to make sure that they have muted themselves just to minimize any kind of background noise. Hopefully everyone is familiar with Microsoft Teams by now, so people are aware of how to do that. And just a note to say that we are recording the webinar as well. So if we could pop on to the next slide, please. So we've got two really brilliant speakers for you today, both of which are Thames Valley Cancer Alliance clinical leads for the personalised care programme. And I'm sure they'll introduce themselves when they come on, but the first one is Dr. Kabir, and he's one of the local GPs in East Berkshire. And the second one is the lead cancer nurse from Royal Berks, which is Mark. As I say, I'm sure they'll introduce themselves. And next slide, please. And so the kind of agenda for today, we've got 45 minutes booked in for this session. We anticipate it'll be around half an hour of presenting, and then we'll have time for questions. The session itself is meant to be really interactive, so if you have got questions, please do pop them in the chat box throughout, and we can answer them as and when we get a pause, or at the Q&A section at the end. So I think I'm handing you over to Mark now.
Thanks very much, Hannah. Hello, everybody. Thank you for joining us today. Yeah, my name's Mark Folks. I'm the Macmillan lead cancer nurse and nurse consultant in acute oncology at the Royal Berks in Reading, and I'm also one of the clinical leads for this programme, the Personalised Care Programme for Thames Valley Cancer Alliance, and I lead for secondary care. So it's once again, it's really nice to see you. What I'm going to start with is a few slides just to introduce Kabir, really, and he's going to tell you about where that sits. My phone's going just at the perfect point when I didn't want it to. Yeah, so he's going to go through the cancer care reviews himself, which will be a lot more relevant to yourselves. Anyway, so the need for the personalised care. So what the personalised care programme is, it's based on the Macmillan Recovery Plan, which has been around for about 10 years. I was part of the original pilot for that, and what it's about is about tailoring sort of holistic care for patients. It's about treating the individual, not the diagnosis, and it allows patients to be involved in their care. And that's important because, as you all know, as the numbers of people living with cancer increases, there's not enough of us around for them to be very reliant on us all of the time. So people have to take responsibility for their own care, and some of that is about that, but also setting up facilities and programs to make that easy for them so they can access help when they need it. And it's as the bottom quote says, it's achieved through supportive conversations and assessments, and it's about putting their care into their own context as well. So it's a personalised care approach. Can I have the next slide, Pete? So I'd just like to run through what happens at each point in the journey. So once a person gets a cancer diagnosis and sort of enters into secondary care, they're seen at a cancer MDT, and ideally we'd do a holistic needs assessment at that point. So that's sort of when somebody enters into our care, and that I'm going to talk about the holistic needs assessment in more detail shortly. But what that does is tell us a little bit about what their needs are at that point. People then go on for treatment in the context of oncology. That's radiotherapy, chemotherapy, and palliative care. Of course, outside of oncology, you can have surgery and other sorts of treatment. And then when the patient finishes their treatment and is due to be discharged, even to an open access follow-up, we'd want to do another holistic needs assessment, because there might have been some changes in between that and the first one, but also some time might well have elapsed by the time we've done all of that. And it's also important that that guides what the patient's needs are when they go back into the community. So all of the holistic needs assessments, care plans will be able to be shared with you now, and we've got the facility to do that. By you, I mean the clinicians in primary care. So they will go through to you in your surgery, and you can see those. So the other thing is that we provide is an end of treatment summary, and this is particularly important for people who are on open access follow-up, and we'd also provide that for you. So this has been particularly successful in our breast cancer service, where end of treatment summaries everybody who finishes end treatment at the Royal Barts and goes on to open access follow-up, you'll get an end of treatment summary which summarises what's going on with them. Okay, so you'll have, to summarise, you'll have at least one holistic needs assessment care plan, and you'll have an end of treatment summary, ideally for these patients. You can then, when that patient arrives back at you, set up your cancer care review, which Kabir is going to talk about, and all of this is very interactive. We share the holistic needs assessments and the end of treatment summaries with the patients themselves, and they're able to discuss that with you, and then you can share information in an open way. So I hope that's quite clear. That's a rough plan. I should say that across the Thames Valley, we've been really successful at putting one HNA in a pathway, normally the second one before people are discharged. We've been less successful at doing two. So we're running at about near enough 100% that all patients will have at least one, but only about 20% of patients will have two. So just so you're aware of that, don't expect two, because there might not be two. Okay, have the next slide then, Pete, please. So what's involved in sort of personalised care and support planning? Well, it's based on holistic needs assessments, which is the sort of bread and butter, really. That's the basis of everything that we do, and it's about identifying concerns. It's about, so basically what happens is we send an assessment out to the patient, they complete it, and then a trained member of staff, most commonly a clinical nurse specialist, goes through that with the patient, and that we agree a care plan, which is then shared. The end of treatment summary, it gives you an overview of what's happened during this, so the care period with us, gives the patient and yourself some idea of what signs and symptoms, how to get back into the system, what things to be aware of, potential side effects. And also alongside that, we've also got quite a wide-ranging, currently series of health and well-being support packages. Mostly they're virtual at the minute, and there's a whole programme of virtual sessions that we provide for our patients. But as of this month, we're now going back to providing face-to-face sessions as well. And sometimes they're general, and sometimes they're cancer site specific. Next slide, please, Peter. So what does a HNA entail? So we deliver them largely in secondary care. We set them up by email or in person, so we let the patient know that to expect one. The patients, it's a simple tick box exercise, and people can highlight. It's a sort of pre-populated pick list. The patients can then choose what their main concerns are. It gets sort of scored. I'll show you in a minute. I'll give you a couple of examples, but we then plan according to those top concerns. I mean, often people can put like 10 concerns down, so we tend to try and concentrate on the top few, just what's the top 4 concerns, but we can do more if we've got time, and we have strategies for addressing these, which we then put down and share with the patients and with yourselves. The way we do it across the Thames Valley is it's all carried out and stored on Macmillan HNA software, and we've got a big database, and we can also provide reports from that. And you get what you see. Can I have the next slide, Peter? Is this, so the assessment is on the left, and that gives an idea. So you get to, for this lady, it was one that I did myself, and she's had some treatment from breast cancer, and she had some edema, lymphedema. So you can see that. So that was her main concern. That was scored 6 out of 10. So I use that as the basis to do the care plan, which is an excerpt is on the right. So yeah, and we can also put links in the document where they can click on things. So swelling, lymphedema, she has some frustration at the pandemic problems she was having. So you get an idea of the sort of things we cover. So it's quite wide ranging, really. We can give advice and share that with you. So that's my bit over, I think. Can I have one more slide just to check? Yeah, I think I'm going to pass over to Kabir now. So thank you for listening. I'm going to be online till about 1 o'clock. So if you've got any questions, we just stick them in the chat. Thanks very much.
Thank you very much, Mark, for that, and welcome to everyone who's joined us today. So my name is Kabir Alawali. I'm the Macmillan GP for East Berkshire, but also one of the primary care leads for the personalised care programme in the Thames Valley Cancer Alliance. And so I'm going to talk a bit about cancer care reviews, and so more a primary care based approach compared to what Mark mentioned, what happens in secondary care, and hopefully how we can use this to really improve our patients' journeys with cancer. Now, so the first slide is what needs to be done in primary care, and so there's requirements based on the quality and outcomes framework in general practice, which I'm sure you're all aware of. So that's incentivization for doing particular things to improve patients' overall health, quality of life, all sorts of measures. So for cancer care reviews, what QoF actually recommends is that there's a first contact. So patients diagnosed with cancer within the previous 12 months who've had the opportunity for a discussion and informed of the support available from primary care. So that's not a full cancer care review. Obviously, it's just an opportunity for contact within 3 months of diagnosis. So I'm gonna come back to that. So but really the key thing to remember is that first opportunity to give your patients a call is an opportunity to actually plan the cancer care review that you will do within the first 6 months. Now, as you can see on the diagram, the orange, so the Thames Valley Cancer Alliance, really we've suggested that we do have a cancer care review within 6 months of diagnosis, and then the other QoF requirement is within 12 months. So what we're basically asking for is 2 cancer care reviews, one to be done within 6 months of diagnosis and the other one to be done within 12 months of diagnosis. So the 6-month requirement is from the Alliance and the 12-month one is from QoF. So that's just worth remembering. So really we're talking about 3 interactions from primary care: initial conversation and 2 cancer care reviews, and I'll come back to how we can fit that around the patient in the coming slides. Can we have the next slide, please, Pete? So how to perform a cancer care review. So anyone, you know, I don't like to say anyone can do it. Anyone who's comfortable doing it can perform it. And so the reason why we have these teaching and training sessions is so that we can make people more confident in doing them, so that everyone feels more comfortable in performing them. Now, a cancer care review should be done in a dedicated appointment slot. It's not one of those things that, you know, you can do at the end of an appointment. Say a patient's come in because they're having some side effects from their chemotherapy and they wanted an opinion on those. You don't just say, oh, okay, let me just quickly do a cancer care review. That may be how things have been done in the past, but we want to get away from that, and we really want to have this specific time slot and time made for these reviews. Because if they're done at the end of an appointment, if they're done for someone who's come in for, they may have coexisting diabetes and need a foot check or whatsoever, and if they're done in that situation, they're not going to be as effective, because you're not going to have planned. And in terms of planning, I'll talk about what we need to think about before we call someone in for a cancer care review. It can be virtual or face-to-face. I mean, if patients prefer virtual at the moment because concerns regarding the pandemic and so forth, I think that's perfectly acceptable. Hopefully there will be more face-to-face in the coming months. It's always worth encouraging a family member to be present, because obviously cancer affects the whole household in the vast majority of cases. So you know, it is worth inviting someone else, and it's worth using a template. And I'm going to talk you through the template, which is a Thames Valley Cancer Alliance template. There are various templates, but this is the one that we are using in the region. Okay. So just to talk about preparation and opportunity of first contact. So those 3 interactions we've got, so the 2 cancer care reviews and that first contact. So the first contact could be used, you know, you pick up the phone and say to the patient, look, I know you've been diagnosed with X 2 months ago. You know, it's an opportunity to ask, how are you? How are you finding your treatments? That's if they are undergoing treatments. Obviously, you know, before you give them a call, you're going to gauge what the aims of any treatments they have are. Are they palliative? So, you know, a first contact is quite vague as to what you need to do. So it would really be a very an approach based around what the patient wants to discuss, something you may want to discuss from your knowledge of the patient. But you will have the holistic needs assessment, which Mark spoke about as well, which you can base your conversation on. So they may have mentioned something. I can't remember what Mark said. It was a lymphedema case, so that may be something that triggers the conversation. So the template should, and the whole contact should be based on what patients want to discuss. That is then an opportunity to gauge what their understanding is of their condition. And, you know, at that appointment, I would suggest that you probably do book them in for the cancer care review at that first contact. So after you've understood what their understanding is, you know, you say to them, look, we would like to offer you a cancer care review within the next few months. You know, you can organize a date for them. You can tell them to bring a family member. It is worth at this point, just because some of these things will come up in the cancer care review, whether you've got all of the information you need. And if you're not sure, for example, if you're not sure if the patient has capacity, then you may want to discuss it with a member of your healthcare team, maybe the GP. You may want to clarify some clinical information if you're not sure, based on their letters at that first contact, what the aims of treatment are, for example, what treatments they're going to have. So really, the first contact is an opportunity to just say hello to the patient, get what their understanding is, and to plan that cancer care review. I've got a link there on how to carry out an effective cancer care review, which will be on the site. Can we have the next slide, please, Pete? So going into the cancer care review, so we've had our first contact with our patient, we've invited them in, they've brought a family member in with them. So now the patient is, like, let's say they're with us, we're doing this face to face. So I think hopefully this is through this is the EMIS template. So on EMIS, you click on Run Template at the top, you type in Cancer Care Review, it comes up there, and you just click on Cancer Care Review TVCA template, and that should bring it up, and that should bring up what's on the next slide. Right, so we've got our patient. We want to do our cancer care review. So this is the template we're going to have in front of us. We've had a brief conversation with them already. So let's say our patient is a breast cancer patient. I'm just going to just make up a hypothetical patient. And so, you know, we've had a look at their treatment summary, if they've got one, or their last clinical letter. So if you remember, the end of treatment summary would be after they're on a follow-up, well, they may have been discharged from their initial treatments. You're going to have, so possibly a treatment summary. You're probably going to have a clinical letter if you don't have a treatment summary, and you're going to have an H&A, so a holistic needs assessment, which Mark talked us through. So I would have had a look at those before you call the patient in. You may have had a look at them in that first contact call as well. So you've got some information on the patient, but the key thing is you need to understand what the patient knows as well. So don't get obsessed with the letters. Don't get obsessed with what's written there, because sometimes the patient may know more, things may have changed in those letters. So really involve the patient. So what you would do is, I mean, you would obviously tick the box, whichever cancer care review this is. Let's say this is the first one, so the first box within 6 months. And then it asks you for diagnostic code. So it's just a quick question. A question has popped up there. Yes, you will have access to these slides after the webinar, so don't worry. You don't need to take notes on what's on these, because these will be made available to you. So the diagnostic code is where the malignancy is. So it will be malignancy of the breast. Or breast cancer. I can't remember what the option is on the drop-down menu. So the primary cancer could be unknown. This could be a patient who's undergoing investigations at the moment, or, you know, to find out exactly where it is. This can take time. You know, we know they've got a malignancy. They may have been detected to have some lesions on the liver, for example, but we don't know where their primary cancer is. So that box would be ticked if you're not sure where it is, as opposed to something like breast cancer, which would go into that diagnostic code. Metastases would be from there's a couple of ways from finding that out. So obviously it may be on the end of treatment summary if they've had that, or their last clinical letter as well. But if you're unsure, you can always collaborate with a GP or with a colleague. But if they've got any evidence of metastases, it's usually staged as M1. But you know, you could argue, well, does that include lymph node metastases? Well, I would probably say it should probably include more distant metastases. So if someone is M1, as opposed to just localized lymph nodes. But I'm not sure what anyone else would think about that, but that's what I would personally do. And the reason for that is because if you've got more distal metastases, then there's quite often more of a burden of disease, and I think that's important to appreciate. Just to mention, sometimes the staging can be difficult from letters. It's not straightforward all the time. So if you do need to just ask, always worth just asking a colleague if you're unsure. Now, staging cancer journey, again, this will be available from the data, but I would probably just say to the patient something like, you know, obviously the general introductions, how are you, and what do you understand by your diagnosis? Ask them what treatments have you been having, and hopefully they'll collaborate what's on your records. So they may say, look, I've had surgery, I've had some chemotherapy for our breast cancer patient, or I'm on a surveillance program because I've had my primary tumor removed, and then I had some chemotherapy, and now I'm just under follow-up on a long-term follow-up. Hormonal therapy, they may be on anastrozole or something, or tamoxifen. So always worth just, you know, based on what they're on, worth just ticking the relevant boxes. Now, some patients will be palliative and terminal. Obviously, with terminal patients and palliative patients, it's important to know that before, and that's why those end of treatment summaries and the clinic letters and the holistic needs assessments are really important to have a look at, because it's you would want to know if the patient in front of you is for palliative treatment only. It doesn't change your approach, because I think we treat all of our patients with the same care and everything, but you do have to have a slightly different approach and just appreciate that someone who's palliative may have different requirements and different needs. So that's why it's really important to know that. Now, just moving on to the next category, it's capacity. Now, so the key thing about capacity is that it's decision specific. So someone can have capacity to refuse treatment, but for example, I mean, this I'm probably going to be far-fetched to find examples of this, but essentially every decision that you're making a recommendation of someone's got capacity has to be individual. So if it did say in the notes, patient does not have capacity to their last appointment, for example, they refused antibiotics, that doesn't mean they don't have capacity for everything. Now, what is capacity? Capacity with regards to medical treatments is they need to be able to understand the treatment. They need to be able to remember that information and use it so that they're able to make an informed decision. And lastly, they need to be able to communicate that decision. And that's really quite key. So understanding, retaining, making that decision, and then communicating it. So obviously the communication can be in any form. It can be through speech, it can be handwritten, sign language, anything. So we just have to make sure the patients have capacity to give consent to having these reviews and so forth. In patients who don't have capacity, as with all aspects of medicine, it is trickier and it's harder to reach a consensus at times. We will talk about, we'll talk about lasting LPAs now. So a lasting power of attorney can make decisions on the patient's behalf if they don't have capacity. Now, on the whole, these decisions about capacity and medical treatment can be made by a doctor based on the patient's best interest. But if there is a conflict, for example, this won't come up in primary care as much, but I'm just trying to explain it because it's on our review template, so it's always worth just having an understanding of it. But if, for example, a doctor wanted a patient without capacity to have a certain treatment and a family member didn't agree, for example, you would need to seek advice on that, and often you have to have a essentially courts have to make decisions. It's probably not going to come up in primary care so much because we're not making decisions on those sorts of treatments as such, but they may have these sorts of lasting power of attorneys or a court-appointed deputy to make decisions on their behalf if there's been some conflict in regards to their treatments in secondary care. So, I mean, I don't want to overcomplicate things, but I did want to explain everything that's on it so that you understand fully all those different boxes. So on the whole, everyone's going to have mental capacity to give consent, but if to any decisions that are made during the cancer care review. But if they're not, then you just need to be aware of the other boxes. So if they have a lasting power of attorney, put their details in, or if best treatments are being decisions are being made on the best interest for the patient. Right, next slide, please. I will come back to the questions at the end, but I will take this one actually as a, so any clinician can do this, and we're encouraging more and more non-GP clinicians to do it, so practice nurses especially. I think it is important. That's why we're doing this training, and that's why I'm trying to go into a bit more detail, just so that everyone understands some of these terms, because as I said, there will be cases which are harder to do a cancer care review. There won't be, you know, by harder I mean, you know, they may not have capacity. They may have had some conflicts of their treatment if they didn't have capacity in hospital. But in those cases, I would suggest that it's worth discussing it with other members of the team, particularly GPs at your practice, if you are going to do cancer care reviews. But most of them will be fairly straightforward. To the next box is consent to share information. Now, this is based around the summary care records, which basically every GP holds on a record of the patient's really basic information, you know, demographics and so forth, and what medicines they may be on, and allergies and so forth. So it's just getting patients' consent for that to be shared with all people who are looking after them, and most people will be happy with that. If they're not, there are specific options that you can click that patient does not want their information to be shared with X, Y, if they don't want it to be shared with a family member. So just record that, but it should be fairly self-explanatory. So, and then the next bit is diagnosis and care discussion. So this is again based around, you know, you would have asked them what they understand by their diagnosis. So hopefully that a breast cancer patient is undergoing all those treatments. So, you know, you would discuss whether they've had any problems and any side effects or anything, any difficulties aside from that. So you could tick that box, and then discussion about treatment. Again, you can add some extra information if you need to. Discussion about the complications again, whether they've had any difficulty with the treatment or with the actual diagnosis themselves. So in the hospital summary, again, you can tick that box if you've got an end of treatment summary or even a clinic letter, but they should, if they've completed their cancer treatment, it should be an end of treatment summary. Now, the next bit is just about this performance scale, and you just, it's fairly self-explanatory. You'd hope no one's at 0% or someone's gone wrong somewhere, but hopefully most patients will be at some state, at some level there. So, for example, requires considerable assistance and frequent medical care would be 50%, and normal being 100%. I mean, that just gives an idea of what the performance status is for the patient, and you just enter that as a percentage. So after that, then the other things that you can do during a cancer care review is you're going to tick whether you've made a plan with them about going forward, whether that's based around the current treatment, so the current problems they're having with their physical symptoms, whether there's been any other plans, which I'll come on to into the next slide. It can be worth doing a medication review, and you may want the GP just to do that. So GPs can do these remotely, but just go from a nursing point of view, just going through their medicines, which ones they're taking, which ones they're not, making a note of them, and then the GP afterwards can just do a medication review based on that. If they need to, they can call the patient, but they probably won't need to. And fine, can we have the next slide, please? Okay, and so the next bit talks about emergency contact details. Do they have a carer? Who would be their contact if there was any issues, next of kin? Resuscitation status. Now, these are difficult conversations to have. We all find them hard. But a decision doesn't need to be made in a cancer care review. It may have been made, but there may be an advanced decision to refuse treatment that a patient may say to you, look, I don't want to be treated. You know, I don't want to have to, you know, if X, Y, or Z happens, I don't want anything further. I'm happy with the treatments I'm having, but it is worth just clarifying that. So, you know, how would you ask this though? it really does depend on the circumstance. So if you've got our breast cancer patient, for example, with us, and the intent for disease is curative, you don't need to necessarily ask that. Okay, you could ask though something like, if you did deteriorate or you found out that things were getting worse, have you thought about what you would do? I mean, that's if you're comfortable asking that. I may do, I may not do. I would probably base it around the patient and what the aim of the treatment was. But if someone, for example, I think this is more valid for patients who are palliative, okay, and on medical grounds, there may well be things like do not attempt resuscitation forms for them, particularly if they're palliative or they've got quite advanced malignancy. So it is worth recording the resuscitation status, which may have been done in hospital, but if you feel that they do need to have that done, so it's not been done in hospital, then it is something worth discussing with one of the GPs. Now, health and well-being. So this just records really basic information. Are they housebound? Have they had the HNA, which Mark spoke about earlier? Health promotion, things, you know, the usual stuff, smoking, alcohol, you're going to record that there, but, you know, just encourage them to reduce if they do consume excess amounts or smoke. Whether they need any psychological counselling or help with regards to that, or they've had anything like that. Again, that may have been identified in the holistic needs assessment, but obviously if someone comes to see you and they're feeling really low, then we would probably need to manage that, and I'll talk about how we would do that in the coming slide. Just the financial aspect, a DS-1500 form is done for patients who are likely not to live beyond 6 months. It does allow them to access to financial benefit, so it's important it's discussed if the patient is is palliative and likely not to survive beyond 6 months. Again, decisions are difficult to make. It's not a crime if you do a DS-1500 and a patient lives beyond 6 months. So if there's any doubt, I would say probably it's better to do it than not. Disabled badges and entitled to prescription exemption. Cancer patients on the whole will be entitled to exemption from prescription charges. So if they're receiving treatments for cancer, or they're suffering from the effects of their cancer or the effects from treatments for their cancer, then they are entitled to that, and so that form should be filled in. It may need a quick signature by the GP. And then referral to social prescribing. I'm going to talk about that on the next slide, please. So you guys may have come across social prescribers. They're usually PCN based, and they're essentially link workers who have a lot more time to spend with the patient than we would in the GP practice. So it's designed to look at holistic needs. So, for example, our patient, you know, who has been having treatments for breast cancer, is being monitored now. She may be a carer herself for an elderly relative. She may have had her income suffer because she's having some nasty side effects. There's more to managing patients than what we used to do, which was to you know, get obsessed with sizes of tumors, try and reduce tumor, try and reduce the tumor, try and get, you know, responses to treatment. That's really important, of course it is, but the whole personalized care agenda is based around looking at the patient as a whole and helping every aspect of their being that we can. So financial, whether that be financial, and what we mentioned before, psychological. Do they need access to talking therapy services? Talking therapy services are really good local resources which can help provide support to patients with all sorts of chronic diseases, but cancer is an important one. So, you know, the previous slide, when we looked at psychological therapies, it's worth considering whether we need to refer them either to psychological therapies, whether we need to refer them to social prescribers who can help out with things like benefits and so forth, and connect patients to reduce inequalities and overcome complex issues. We have a social prescriber with us who I will come to at the end just to talk a bit more about their roles, but we sometimes get some really complex patients. with really complex social needs more than anything. The medical needs may not be that difficult, but people have all sorts of difficulties in life, and we know about these. And I think having a dedicated key person who can help them, who can help direct them to the appropriate organisations who can help them, whether they be charities, whether they be the local council, is really important. Because in primary care, we don't do it, and I'm honest enough to say that. And I think everyone on this call who works in primary care knows how stretched things are. And also, in all honesty, I probably wouldn't know all the people who would be able to help our patient if they were having difficulty with some of the non-medical aspects of difficulty. I've got another link there on personalised care, which explains social prescribers and their roles. But if we've got a social prescriber with us, I may borrow them at the end of these slides. Can we have the next slide, please? So ending the review, how are we going to do that? So we've spoken about filling out the template. So you may want to refer them to an allied health professional. So whether that be the GP to discuss whether they need a DNAR form, whether it be the specialist nurse because this patient's struggling with the side effects of treatment. Sharing her holistic needs assessment with secondary care. Sorry, I think that was a slight typo. You may want to share this cancer care review with secondary care. Apologies. So the holistic needs assessment we should have in front of us, but it's the cancer care review, which may have some information which we've obtained, which we may want to send to their clinical nurse specialist. But to be honest, a lot of the help that can be offered may be through social prescribers with these other aspects of life, whether that be financial, or, you know, are they using substances or something, complex issues which can really be not necessarily fully medical, but factors which are important to the patient. Obviously, this is our first review. We can organise our second review and just talk about that when it should be. And after our first year of diagnosis, it's advised that patients have an annual review. So an annual cancer care review after the first year. Always worth making sure the patient, we always safety net our consultations, but worth making sure the patient is aware of whom to contact if any issues do arise. Could I have the next slide, Pete? We've got some further resources. Can I just check who is the social prescriber? I'm just going to go into the chat. Someone very kindly typed in Liz. Yes, so I think you've mentioned there. Yes, absolutely, that's completely right. They are not clinical. Mental health side of things. A lot of social providers have started doing this now. Is that suitable, do you think, as you have mentioned nurses doing it? Liz, thank you for that. No, I would say probably it may be in the future that social prescribers can do cancer care reviews, but at this stage, no. I think we would need to give more training for that. And as you mentioned, there is a lot of quite difficult information which you sometimes need to interpret, which is quite clinical. So no. Liz, do you have anything else to say about that? And yes, mental health side of things, financial, that's what I was referring to. Fine. Okay. Hannah, is that, I think you're talking through these last few slides, aren't you?
Yes.
Yes.
So Pete, if we just pop on to the next slide, please. So it was just to highlight, and actually it's, you know, this might be quite relevant with Liz's point there, that there is going to be some further training run across the Bob ICS footprint. So for Berkshire West, Oxfordshire and Buckinghamshire. It's being run by Oxfordshire and Buckinghamshire CCG, but they are welcoming people from across the patch to join, and it's actually 4 individual sessions, and it starts in June, and you'll see just on the slide there's individual sessions about what they're talking about in each of those, and so appreciate that what Kabir's done and Mark have done today is a really nice overview, but for those of you who perhaps feel that you would like a bit more dedicated support and some further training on this, we just wanted to highlight that that's available. As I think Peter's mentioned higher up in the chat box, All of this information will be going out in the next newsletter, which goes out next week to everyone. And if you would like to attend, then you can either contact Judy directly, who's Peter's equivalent at Oxfordshire, or you can contact Pete and we can get you sent through the information and get you signed up to those sessions. We'll pop on to the next slide, please, Pete. So it's just a little plea from me that obviously whenever we do these kind of sessions, we're always after some feedback to see how they've gone on. And also helps to form our kind of education plans moving forward to see whether, you know, whether we actually want to deliver more sessions like this, what else you would find helpful. So I'll pop a link in the chat box now. It's 10 very easy, very quick questions. So if anyone has got a spare moment just to fill out the feedback form, I would really appreciate it. And then I think last slide, Pete, is just around Q&As. So we've had a couple of Q&As come through, questions come through on the chat box. I think Kabir's done a brilliant job of answering them as we go. Let me just check. I think one that we might have missed, Kabir, was around is there a separate template for the QOF review, or whether they can use the TVCA template for both?
The TVCA template can be used for both. I'm fairly certain of that, yes.
Yeah, that's correct. Yeah. So I think in the latest QOF guidance, they do recommend the Macmillan template in there. The TVCA template has been developed off the back of the Macmillan one, so it includes very similar information and it can be used for all of the reviews. And yeah, I think Shelley Orton, who's our lovely Macmillan partnership manager for the patch, has just put in the chat box a link for a link on social prescribers as well, and how they can support primary care and personalised care agenda. So Shelley, I think what I'll do is I'll probably add that into the slides with the useful links section. So lovely.
So we've just had a question come up, Hannah, about the TVCA template is not on the system at my GP. Will this need to be uploaded?
It should be on all of the EMIS practices. I'm not sure who that's from because it's just got initials. If you let us know which practice you're at, then Peter and I can take that away and make sure that it's definitely on there.
That looks like it's a common theme. So Rachel's reported couldn't find it either.
Yeah. Okay. Thanks. Yeah. No, that's really helpful to know. If you're happy to feed that into us as which practices. I mean, obviously, I can see Rachel there. Your practice names with it. Then Peter and I will take that away and have a look into that. I think Dr. Sachdev, you've got your hand up.
Yes, thank you, Hannah. Can I just say thank you to Kabir, Mark and yourself for an excellent presentation really today on cancer care reviews, and a thorough presentation. Really great. I'm just going to add a couple of quick comments, if you don't mind. One is, and this is, you know, this is what we do medicine for, really. You know, I feel we should never underestimate the impact we have of contact with the patient and their family when they've been diagnosed with a serious illness, when it's sort of solicited or provoked and we proactively contact them. Patients really appreciate, they understand that we care. And I think, you know, I would, and this is the ethos of the first 3-month and 6-month review, is to actually make contact with them. You're not going to solve all their problems, but at least showing that you care goes a really, really long way. So it is something we do anyway without a tick box or income generation anyway, I'm sure, when we are such caring people. So I would recommend it. Bonuses, we get paid for it and get points. And the other aspect I just want to add really is that the cancer care review template doesn't have to be filled in completely at the first conversation or even the second conversation. You have to judge the patient and their need and continue filling it out as in an evolving fashion. So, you know, I think the cancer care review is really, really useful consultation. It's a consultation tool in a sense, and it's been designed to be a consultation tool. And you just go through some of these tick boxes as a not forgetting about, you know, for example, the prescriptions and the disabled parking. These are all things which actually make a big difference to individuals. And really, I can't extol the virtues of following the Thames Valley Cancer Alliance template enough because it incorporates the Macmillan and lots of other sort of templates which we all put together. But well done today. Thank you so much for great information there today.
Thank you, Anant. And just to second that note, it's really important that, I mean, I don't like to say we should give cancer patients that extra care because everyone should get the same level of care. But obviously, there are these mechanisms for doing this. And the reason behind that is to really give extra support for these patients because cancer is traumatic. I mean, as you know, I always say I teach medical students a lot, and I always say to them about 70 or 80% of the consultations I have, people at the back of their mind are wondering, well, what else could be wrong with me? And is it cancer? And, you know, even for mild symptoms which are persistent, like, well, you know, could I have cancer? You know, particularly above a certain age group, obviously that's not with children, but say the over 50s, over 60s, you know, people worry about this. Cancer is a terrifying word to a lot of people. So I think we really need to take these opportunities to see what we can do to help these patients. And as you correctly say, not all of that template needs to be filled in at the same time. Obviously, as I mentioned, some of it might not be appropriate for for example, the resuscitation status in our patient who's probably going to be on long-term follow-up and curative intent. It won't be relevant, but I just wanted to go through a lot of it just so that everyone's aware of what the different boxes mean. Thank you.
Thanks, Kabir. So I think we're ever so slightly a few minutes over time, and I'm sure people have got lots of other things to be getting on with. So unless there's no other burning questions, we'll call it to a close for now. Pete from the CCG has kindly put in the chat box his email address. So if you do not have the template on your system, please could you drop him an email and he will get that sorted for you, I'm sure. And also another really useful link from Shelley from Macmillan as well, with a new learning hub that Macmillan have got with some further courses and information that you might find useful. So just last plea again, I'll pop the feedback form link in the chat box again, and if you have any questions at all that come up afterwards, please don't hesitate to get in contact with us. And thank you very much.
Thank you, everyone.